So let me ask you a general question. So when you have a call come in and it starts off and dispatch says such and such an address, and then you hear the word pediatric, what do you hear immediately after that? Basically Charlie Brown's teacher, right? You hear the wah, 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 because after you hear pediatric, your brain shuts off, your sphincter tone increases, and you're just like, oh my God, it's a kid. Worse off, you get this, where it's pediatric possible arrest. Right? Now, there are obviously tremendously bad things that are a result of this. However, when we start looking at the comparison between adults versus kids, given the choice, and you've only got one choice, would you rather take care of a child or an adult that's in cardiac arrest? Who would say an adult? Okay. Who would say a kid? Who doesn't know? Who doesn't care? Why don't you put your hand up? But the thing is that when we look at the etiologies behind cardiac arrest in adults, I mean, we've got 8, 10 different or more possibilities, and some could be a combination of those things. With kids, it tends to be maybe 1 or 2. I mean, overall, I mean, there are specific things that go wrong, but overall, we're looking at what? Either volume or air. And most of us in here can fix just about either one of those. So what I'm going to talk about today with this is a little bit in, see if it clicks. It was. Yeah, we'll just do this. Oh, I know one here. A little bit on just some things to consider, either in prevention and or if you run across a case where you do have a pediatric arrest, some things to kind of think about. And some people actually have taken this and actually kind of adjusted their protocol simply because of it was not as efficient as it should have been. All right. So the first thing, this is the easiest out of all of them. You see it coming. What do I mean? Well, when you walk in and you look at said child, you basically get one of two presentations, right? You walk in and you see them and you're like, huh, okay. Or you walk in and see them and you're like, yick. Right? Sick kids look sick. Okay? Dying kids look like they're dying. Well kids, how do you know if they're well on average? Yeah, they're screaming. I love screaming kids. And their color is decent. If I got that when I first walk in, I'm like, okay, dodged a bullet at least temporarily. That being said, I'm sure you've probably seen this before, but if not, well, there it is. This is the initial beginnings, what we call the pediatric assessment triangle. This is your basically your 20-foot visual observation. And these are the things that we're looking for, basically either changes in appearance, work of breathing, and or skin circulation. And if you see any abnormalities in any one of these or a combination of these 3 areas, you've got a sick child. Now, there are sick children that will look exactly like they should be, and there won't be any problems here. But obviously, as you go further into your assessment, you're going to find those things. What this will do is that it heightens your suspicion quicker to start acting a little bit sooner, because obviously, if we show up and there are any deficits here, that again is either a volume or an airway issue in most cases that we need to either get on or get on sooner than what we would if we hadn't had the deficits here in the first place. So appearance is just, again, their appearance. You know, what do they look like when you're walking up to them? You know, are they up and flailing around versus, God forbid, how many of you had the case where you're pulling up to the curb and mom or dad comes running out with a child and they're in the arms like this. And all you want to do is put that thing in drive and just go away because it's like, oh, this is terrible, right? Same thing with interactiveness. Most kids that are awake and alert and oriented, what should you not be able to do with them? Okay. What's that? Right. They want to be clingy. They see you as a stranger. And even more so, the closer you get to them, and if you can get right up in their grill, I mean, like nose to nose, and they don't flinch, what's that tell you? That's bad things. Yeah. So the lights are on, nobody's home type of thing. Same thing with the consolability. Mom will tell you, it's like, or dad will tell you, I've been crying and crying and crying. I'm doing everything I can. I cannot get them under control. Okay, that's an alternate mental status. Same thing if they have any kind of issues with, high-pitched or low-pitched or kind of croupy or stridorous type of, cry or anything like that, or if they're just looking at you, like I said, staring straight through you and not budging. As far as breathing goes, I'm going to show you a couple of examples here in just a minute. But do you hear anything that you shouldn't be hearing? Obviously, do you see anything you shouldn't be seeing, like retractions? There's all kinds of retractions names out there, but retractions, if you remember nothing else from the rest I talk about here, retractions are only one thing, and that's bad, period. Okay? Because what they're doing is they're trying to compensate for some kind of deficit that they don't have otherwise. Nasal flaring, obviously, and apnea, grunting, head bobbing, all those types of things are indications that they're in some degree of respiratory, at least respiratory distress. And then, of course, and again, if they're any color other than pink, not good. All right, so there's our first patient. You walk in, you see this. Where's your concerns? Yeah, so you're looking for the doll sign, right? Talked about that earlier. But you can see she's tripoding a little bit. What else she does? Drooling. So we got that. What else do you notice about her mental status? Yeah, she's focused somewhere other than you, either because she's getting tired or because she's concentrating trying to ventilate, right? So in this case here, would you say that at least there is an abnormal appearance? Sure. Is there more than likely also an abnormal work of breathing? Probably. So again, the more of those types of deficits you have, obviously the worse the patient is, and this is where we got to get a little bit more aggressive with them in some cases. All right, but she should do okay. How about this guy? Yeah, this is not a Smurf baby, okay? But it looks like it. Now, in this case here, we've got something called, cyanosis centrally here. What is that cyanosis obviously an indication of? Yeah, either bad perfusion and or hypoxia. And what's the one thing that makes kids bradycardic all the time? Lack of oxygen, right? So this could be a couple of things you see going wrong with their vital signs as well. However, what's the easiest way to fix this? However they're going to tolerate it, right? Give them some oxygen, ventilate them if you have to. And most of this resolves itself pretty quickly, which is nice with kids. How about this? Yeah, they get worse as we go on, right? If you show up on a scene and it looks like somebody with an invisible hand is doing CPR on that child, that's not good, right? Sternal retractions in this case, you can see that obviously. So he's really sucking air trying to ventilate. But you can also, if you can kind of see it up here, you can see his nose, wide open. He's trying to open his airway. And what do you notice about his mental status? Yeah, he is straight out just like focusing on, please don't let me die. Even though he can't say that, that's kind of what he's getting at in this case here. But again, it comes back to this is either a ventilation or a oxygenation or a circulation issue. We can ventilate this child, and sometimes that may be, again, just the beginnings of what we need to do for them. Okay, so, lots of different possibilities. Let's look at one more here. What's this? Yeah, modeling. What's modeling normally a result of? Yeah, it's an oxygenation issue. What's happening here is that as those, especially in the lower extremities where you start to see it more often than not, is that circulation is impaired because the heart's not beating as fast as it should because it's hypoxic. The blood pools down in these lower areas, partially because of gravity and partially just because of bad flow. And on top of that, your cells are built to want to be circulated. So they've got a built-in mechanism that if that circulation is not doing what it's supposed to do, it releases histamine and other chemicals to dilate the blood vessels to hopefully bring more blood in. So what you're seeing here is a result of those blood vessels dilating, those capillaries leaking, and it's just kind of sitting right there. Now, here's the only catch with this. So we resuscitate this child. They're back to normal-ish as much as they can. Is that going to go away? Probably not totally, right? Because it's, again, transfused fluid into tissues. It's not going to automatically just suck itself right back into the capillaries. So you could still have this there, but your child is otherwise resuscitated. So keep that in mind that it may not totally go away, and that's okay. All right, so for our last one, what would you do?
Where's my phone? Did you ever connect with Dr. Beldowitz for tomorrow? What?
You're talking out there.
Yeah, this is going to get good. Like, that was bound to happen at some point. Yeah. God love technology. Okay, so with our last little guy here, what would you do with him? There's only one thing you got to do in this case. That's run. Right? He's ready to knock your block off. Is actually it's kind of a neat sideline. This kid's grown up. He's already been through college. All the money that he made off his memes almost put him through college with all the money he made off of this. It was ridiculous. I saw a story of it one time somewhere. What's that? No, that was him. He's already grown up. He's like in his 20s now. But a family member, yeah, you probably have to watch out for them too. All right, so the key is that obviously when you see those signs that we just showed you, there's obvious deficit there. So as soon as you can correct that, the quicker you can correct it, the less likelihood you're going to have the complications and maybe preclude, if not already erase, the possibility of them going into cardiac arrest. All right, the next thing, right? Slow heart rates in kids is no bueno. Now, the thing is, what's a slow heart rate for a 2-year-old versus a 6-year-old versus a 9-year-old versus a 13-year-old? And a lot of us can guess, but that's why we carry our cheat sheets, right? There's very few things that I would ever go on an ambulance shift and not have with me, and this was always one of them. So I figured 2 things. 1, if I need it, well, I got it. And 2, if I've got it, it wards off evil spirits and I won't need to use it. And fortunately, more times than not, that actually fell into place. So when we look at the development, and we obviously look as you get older, those heart rates start to decrease because the heart gets bigger and there's more volume and more output. But in those younger years, they're relatively brisk. So you have to kind of look at relatively what's bradycardic for that age range. And even though it looks decent, right, it may not be. And bradycardia in kids usually is a result of a number of different things, but the biggest thing is what? It's hypoxia, all right? These kids that either have a respiratory compromise or some kind of circulatory compromise, they get hypoxic, they get hypoxemic, then they get hypoxic. This is what puts them into extremis. And kids can compensate for up to a certain point. And yes, they got good pipes, they got good pumps, they got brand new stuff. But even then, it has its limits. And once it reaches that limit, we see them go from good to all of a sudden, they fall off the cliff seemingly. And it's like, well, what happened? Well, they've been climbing for quite a while. We just didn't pick up on it. Or we didn't get to them soon enough. Or the parents didn't pick up on it. And then when they do call us, they've already fallen off the cliff. We show up already in cardiac arrest. We've got 10 times the work. So however the scenario plays out, a lot of times this is one of our major culprits that we're looking at with these kids. And there's lots of reasons, obviously, how they can get to that point. This is just a partial list. And whether it's upper or lower airway, sometimes it's a little bit of both. This may be what we're dealing with first. Okay? Any of these types of etiologies that if we can reverse it, and obviously maybe not totally, but at least get them oxygenating a little bit better, it's going to promote a less likelihood that arrest is going to happen. Now, here's the thing. Could you have, for example, a child that's in severe anaphylaxis, and yes, you've got them oxygenated, ventilated, and God forbid, intubated. Well, let's say we've got that far. Could they still arrest on you? Sure, right? There's no saying that the kid can't arrest even though we cover our bases, but the point is that if we don't, and we don't address the simple stuff, especially with the kids, they will arrest. And that being what it is, a lot of this can, again, prevent a lot of those problems. We just have to obviously take care of what we need to when we were presented with it. These things will appear in that primary survey. They'll appear in that primary triangle that we look at when we look at appearance, work of breathing, and obviously skin circulation. All right, so how do we differentiate where they're at? And sometimes it's easier said than done, but when they're in what we call respiratory distress, one of the keys about this is that their mental status is still relatively intact. They are slightly hypoxemic, but they're still perfusing enough to their brain, and the brain's like, okay, we're at our minimums, but we're good. And the level of consciousness is still remaining. Sometimes, though, you have to take that with a grain of salt. Because how many of you come across special needs kids who were already altered to begin with? Okay, so their baseline may be somewhat altered to begin with. And we don't know that until either we've seen them in the past and or the parents can tell us, oh, no, he or she is normally like that. And you're thinking, really? Okay. And you don't really trust them, but trust them because they wouldn't want to tell you otherwise. Second thing is that obviously now that they're compensating, their respiratory rate, their heart rates, all are going to be elevated. And then we start seeing those external signs sometimes. And we don't see all of them. And sometimes we miss them because, again, how many have seen actual nasal flaring on a child? You know, it was probably there, but we're so busy trying to do X, Y, and Z, we forget sometimes A, B, and C, right? And it's not that if it's missed, it's a big deal. But the point is that if you see it, why do they do this in the first place? And not because they're in respiratory distress, but they are. But how are they compensating? What's the benefit of that, especially with the younger kids? Yeah, up to a certain point, about maybe 2 to 3 years old, their brain is still pretty primal. Right? And the only airway that this brain knows is right here in their nares. They don't realize they got this huge pie hole underneath their nose that can suck air through, right? So they don't see them going, you see them going, you know, with their nares flaring out because they're trying to increase the diameter of their airway so that they can ventilate a little bit better. And it's just a part of their progression as far as how they develop. Now, with everything else, right, you see these other types of extracurricular activities that will be used sometimes to help them ventilate because they are trying to get more air in. This is what we call head bobbing. Now, everybody kind of gonna, oh. And I agree, but is she in any kind of extremis here? No. I mean, she's resting. She's obviously got a little bit of respiratory effort increase, but she's not dying on us. I mean, she's on oxygen. She's with her mom. Everything is in, you know, for what that's worth. And they're filming her, so I hope to God, you know, someone would be there to resuscitate her. Yeah, it's like, watch what happens next. But that head bobbing, we all do it, whether we realize it or not, especially this time of year. You get a head cold, and if you're not going like this, what are you doing? And it's just you cock your head back and you think, well, it's just part of the maneuver. No, it's that force that you're trying to create to suck the loogies back down your throat. And, you know, hopefully you don't swallow them, but sometimes you do. Right. But this would be a continuous with their ventilatory pattern, is they just keep doing it. And again, it's just another way of trying to get a little bit of extra effort, get a little extra volume in. As far as retractions and sounds go, and you can see the retractions, but you heard that, what's that? Yeah, that's what we call grunting, right? It's not like Tim the Toolman Taylor goes, hur, hur, hur. But grunting is like, and when they're grunting, what are they trying to do? Yeah, they're basically trying to keep their lower airways open, right? They're creating back pressure like their own little peep to try and open up those lower airways. So kids that have exacerbation of their asthma, bronchiolitis, bronchitis, pneumonia, all that lower airway garbage, you may pick up on that because they're trying to keep those lower airways expanded because they're plugged up with something. And they're just trying to make sure they get an adequate airflow. And they'll continue that until it gets fixed. And that's the good thing, because once we establish enough airflow through there and we open up those airways with a bronchodilator or epi or whatever we're going to use, what happens most of the time with that grunting and the retractions? They go away. It's like magic. Okay? So you got that. Now, as far as respiratory failure goes, this is obviously now a little bit of a change. So we talked about with distress, how their LOC is going to be relatively normal. Here, not so much, because now either their circulation and or their oxygen level in their blood is well below bare minimum. And so they're not perfusing their brain very well, and or whatever's perfusing their brain is not full enough oxygen. And the brain, as complex as it is very simple as far as its needs, right? It wants sugar, it wants oxygen, it wants something to bring it up north. And if any one of those three components are screwed up, your brain says, okay, too bad, so sad, down goes your patient. Well, the same thing here. So we start to see a change in their level of consciousness. We start to get more noticeable if they weren't already, retractions, because they're working even harder to ventilate. But now we start to see that change in their heart rate. Now they start getting bradycardic because now that heart that's supposed to be going 110, 20, 30, whatever, it's running out of gas because it's just not being resupplied. Okay? Just like the old Chinese saying, no tiki, no washi. Well, same thing here. If that heart doesn't get any oxygen, myocardium can't fire, so the heart rate starts to slow down. Output drops, blood pressure drops, perfusion drops, mental status changes, down we go. And as a result, you're going to have, again, poor muscle tone, going the wrong way, sorry, color changes, and obviously changes in their breathing as well. This will be the child that, again, lights are on, nobody's home, you can get right up nose to nose to them and they don't flinch in some cases. And that's scary. I don't like kids that do allow me to get in their personal space. Okay? I like angry, retracting children. So just to give you an example how severe those retractions can get and how forceful those ventilations can be, let's see this. This is a child that's actually in DKA. DKA. All right. So what you're seeing here are very forceful, deep, but slow ventilations. And you can see the retractions obviously on the sides as well. It's in very severe distress. Here's the thing. All right. So you're not really sure where they're at if they're in distress or failure. And you're like, oh, what should I do? If you can put a BVM mask on this child's face, A, and B, even more so, blast air through it, and this child doesn't flinch, what's that tell you? They need it, right? They should be fighting you. Again, I like kids that fight. And if they don't, or they allow us to do what we're supposed to do to save their life, that's not a good thing. Now, we still need to do it, and hopefully at some point they do start fighting us, but they may not. Okay? They may be compromised to the point that they can't at some point because they're too tired. Because they will tire quickly. Their muscle mass is not as big. They can't compromise as long as we can when it comes to that, especially with ventilation. So what we're looking at here is that if we've got any of these signs or symptoms here, you've got to be ready for that child to arrest. Okay, this is that pre-arrest, basically, period that we're looking at here. And obviously when that happens and the respiratory arrest occurs, eventually that just leads down the primrose path to cardiac arrest. And usually you see one, you see the other. So the respiratory aspect, again, we can fix this from the outside. We can ventilate, we can oxygenate, we can do what we have to do up to your level of care. And again, the basic matumors, the basic pieces of equipment work with kids. Don't be afraid to do them. Because the more of that stuff you can do, obviously they need it. All right. So the third thing, what we're looking at here is that, well, sometimes it just comes out of nowhere. You're thinking, how's that possible? Because you just said, we look for volume issues, we look for air issues, right? So what could it possibly be that all of a sudden the child's good and the next minute the lights are off? Well, there's a couple things, right? First thing is that it could be something they've got internally that either they are or they're not aware of. And the first thing is that this child may have some kind of inherited cardiomyopathy. I'm going to show you a couple of examples here just in a second. Most of these parents, if not all of them, already know this. They've been diagnosed and they know. But still, even having this is not a death sentence, but it obviously compromises their heart's ability to function and can be basically a trigger. The other thing is what we call long QT syndrome. And this is something that sometimes, unfortunately, gets diagnosed because the child goes into cardiac arrest because there's no family history of it, nothing's ever happened, and now all of a sudden, genetically, somehow this child has gotten the bad draw, and something happens, and down they go, just out of nowhere. I'll give you a couple examples of that here in just a little bit. Obviously, a traumatic cause can be something, as we all saw back last January with the Buffalo Bills player that got knocked out, and it was probably the most vivid example that I've seen in a very long time, where he took that blow to the chest and basically put himself in the V-fib. That's what we call commotio cordis. So we'll talk about that with kids here in just a second. All right. Now, there's lots of different types of cardiomyopathies. I'm not going to go through all those. That's a lecture in and of itself. And quite honestly, if y'all want me to come back and tell you about it, I got a great lecture on it, but it is boring as hell. You don't want to hear it. All right. But I'd be glad to do it if you want me to come back. This is just one type here, though, that is more likely to cause a cardiac arrest. Is what we call ARVC. And what you have here is that basically the myocardium in and of itself, again, this is all genetically caused, is that their muscle gets replaced by fat. And obviously fat doesn't contract very well, doesn't obviously going to do what it's supposed to do. So the larger the mass becomes, all of a sudden now what we start to get is a dysfunction in the ventricles. And what eventually starts to happen is that the signals coming through here, through the Purkinje system and all that, start to deaden out because the fat acts as a very good insulator. And what's going to happen is that the signal is going to get eventually screwed up, and the person will probably go into either some type of VTAC or VFib just out of nowhere. Okay? Because normally kids go into asystole when they go into cardiac arrest. But there are these causes that can put them into VFib and VTAC, which if you've ever taken a PALS course or some type of advanced course, we're like, why am I worrying about defibrillating kids? I'm never going to have to do it. This is probably the one time you'd have to. Now, the only problem is that because of the underlying condition here, your defibrillation may very well lead into an asystolic child that you can't get resuscitated. It's just, again, the cards have already been stacked against these kids, unfortunately, because structurally, their heart's just a mess, all right? So there's that possibility. Or the other genetic component, as I said, could be long QT. And again, just a side story, I'll give you one here real quick. When I was still living in Louisiana, I had two of my students that were out on clinicals. They responded to the high school for a 16-year-old female that had gone to cardiac arrest on the track. Apparently the story goes that the gym teacher told them to go take a lap around the track, get warmed up, they were going to come back and do their thing. She got about 3/4 of the way around the track and she just face plants, doesn't get up. Now, of course, seeing this, fortunately, the trainer, gym teacher go running over there, she's cardiac arrest. Call for the AED, they start BLS on her. They do get the AED on her before the truck showed up. They did defibrillate her once with the AED, woke her up. She was awake and talking by the time the squad showed up. So they take her to the hospital. She gets worked up, come to find out that eventually finds out she is 3rd generation long QT. It does tend to skip generations, but both of her parents had the marker for it, but neither one of them were ever symptomatic. And on her mom's side, both of her parents were markers genetically for it. So it's what it is it's an issue with the channels that allow sodium and potassium to basically go back and forth. And there's 3 different versions of it. So they all have kind of their unique trigger, right? That being what it is, we can also identify this sometimes that we get this child that's maybe had a syncopal event or they're getting bradycardic, not feeling good. We all do the 12 lead. Look at the top of your paper. Right? You're going to see it. That thing calculates intervals very, very well. If that interval is on average for most people above 0.43 to 0.44, then they're in this. And we might be the first people that see it sometimes. So look for it. But what precipitates the event is usually one of 3 things, and it depends on which type of long QT syndrome they have. So the first one is usually induced by some type of stress. So the first one, a lot of times we see the stress. What's one of the most stressful activities that someone can do is exercise? What's that? Running is close. It's actually swimming, yes. Okay. Which I need to get back in the pool because my stress level's way up. But this tends to be one of the more common etiologies. Now the problem is you're going to get called for what? You're going to get called for a drowning because they arrest in the water, right? So we got that complication. But what set it off was that strenuous exercise. Her case, the girl I told you about, running around the track. That set hers up because she ended up with long QT1. Number 2 is more of kind of a reaction due to a stimulus. So you're, a child, you're sitting there playing your video games, got your headsets on, mom or dad or somebody comes up to tap you on the shoulder to say, hey, dinner's ready. You didn't hear them. Or it's like someone coming up behind you and going, hey, just like that. Just like that. I always get one person every time. And what happens is that, and some of you also maybe didn't jump, but you got that nice warm fuzzy feeling. Yeah, well, that rush of adrenaline all of a sudden now bombards the heart, screws up the channelopathy that's already there, and that startling mechanism is what sets them into VFib. So that may be something in the history that precipitates it. The third one is the least dramatic, but also the most insidious, because most of the time with the long QT3, what happens is that said child goes to sleep and then just never wakes up. Happens sometime and they think it's something related to the REM cycle. They're not sure exactly, they being the experts, but they just don't wake up in the morning, and a lot of times these are the ones that we don't resuscitate because they've been long gone before we even get to them. All right, but there's medications that can cause this as well. Okay? Does not have to be genetic in nature. As you can see, this is just a partial list. If you Google, long QT syndrome medications, you're going to get a list of like 1,000 different medications. Most of them are over the counter. Some are prescription, obviously. A lot of mental health meds, a lot of respiratory meds are on that list. And a lot of that stuff is probably some of this you've got either on your person now or on your truck or in your homes. And it's not to say that everybody's overdosing on this stuff. It's just that these can have that interaction with that abnormality they have in their heart and cause the same problem. Okay? So history as far as what they took medication-wise is very important because that could be the key to figuring out why they went into cardiac arrest in the first place. All right, so real quick about the commotio cordis, like you saw the evidence of it, but this is exactly what it is. Now, why do you think that children are a little bit more likely to develop this than adults? Okay, so they got more pliable bones, so they don't absorb the energy very well. What else? What's the thickness of their muscle and skin compared to ours? Less. Okay, so again, does not retard the kinetic energy as much as it should, so they absorb more from a lesser blow, and they're just, reaction times are slower. How many of you ever been to like a pee-wee or a t-ball game, and there's 3 kids out there, and they're trying to catch the ground ball, and the ball goes through their legs, and then they do what? Right? So the reaction time is slower, so they're more likely to get hit in the chest, and that can cause a problem as well. But even with that, even with those things that preclude them, the problem is that this is the 1 in a million shot. All right? These kids are normally healthy. They normally don't have any kind of underlying health issues for the most part, but they get hit by an object, typically a ball of some sort. It could be a punch. It could be they run into something. Who knows what it is? Typically, the velocity is not too bad. It's around about 40 miles an hour, give or take. And what happens? Well, that more pliable, okay, less muscular rib cage, in this case, kind of caves in. More energy is delivered into the chest than normal. And it just happens to stretch out, like you see here, stretches out that membrane to the point where those channels, just at the right point, open up. They get flooded with sodium, potassium rushes out, goes into chaos, and all of a sudden, the next thing is they take 2 or 3 steps, and then down they go. And they're already in VFib before they hit the ground. Right? Now, the good thing is, 9 times out of 10, these things happen at some type of event. And usually it's one of us, okay, or somebody is there that knows what to do, and there's usually an AED on site these days, unlike before. So the resuscitation rates on these instances is fairly good because there's a very low lag time between when we're on these kids and obviously when they get the first defibrillation. Because most of the time, even if it's an AED, it's going to usually indicate shock advised. Okay. Now, that being said, the same thing happened with that gal. The time that it took to get to her and obviously get her first defibrillated, even though hers was a long QT issue, again, she did survive and she's still alive today. Now, this is to give you an example of what this looks like. Again, I don't mean to pick on the younger folks here, but I will because I can. And so this comes off of what's called a VHS cassette recorder. Okay. I did, and I know what, I even tried to use the head cleaner for this thing. You can see how well that worked. But the thing is that this is obviously an older version, but what you're going to see is that this is going to be your patient right here in about 20 seconds. He's going to take a very quick blow to the chest. He's going to take a couple steps, and then down he goes. So watch this. He's going to get hit right there. Okay, well, you got a point taken away, but no, I'm done. And right there, he's out. Okay. And again, he's like, "Are you okay?" Now, this goes on and on, but he was actually resuscitated, and his outcome was good. But you can see how it doesn't take a whole lot to cause that cardiac arrest. So those are some of the things that, again, can happen kind of suddenly, just out of the blue, and still produce the same problem, which is obviously that cardiac arrest. All right, let's look at the fourth thing. Now, your opinion whether or not epinephrine is good or bad, or I don't have enough, I have too much, whatever. What concentration should I give? Blah, blah, blah. Epi is still considered good, especially with kids. Because typically what it comes down to is that we use epinephrine to, vasoconstrict and obviously just kind of reactivate a lot of the different processes that have been shut down. This literally, for all intents and purposes, just like jumpstarts the heart. Right? It gives them that kick in the pants that they need to kind of just get over that threshold so the heart will restart in a lot of these cases. But the longer it takes to administer it, and again, we're talking minutes, every minute that goes by is a bad thing. So I'll give you an example here. Now this was a study that was done in hospital. So they had the code card like literally right outside the door. They were literally like 3 steps away from the room. Unlike us that, what has to happen? Well, the event has to happen. Someone's got to see it. Someone's got to call us. We got to get in the truck. We got to show up. All of a sudden we get there. We're like, oh my God, it's a kid. We got our head together. Then we decide we got to do CPR, get the IO started, eventually get the thing going. And then now we give them epinephrine. And how much time's gone by? Even on a great response, a lot of time. This right here is just showing that they did this study that with over about 1,500 cases, just from a minute delay, okay, the percentage as far as survivability dropped from almost 40% to less than 15%, just from 1 minute delay. So that's the crux that we have as pre-hospital providers. And this is why our survivability rates suck so bad, because it's not so much us, and it's not. It's that we just can't get to them fast enough. That's the problem. It's time is not our friend in this case, especially with kids. And as you see, with every subsequent minute that goes by, how quickly that survivability just drops off. Right? To the point where, you look at this whole scale, where are we on your average call in your area? Think about it. Where would you be on this line right here? I heard like 12 minutes, 6, maybe more than 20, sure. And and I'm sure you've had it. You get there and you're doing what? You're just going through the motions because you know that there's no chance. And that's I've been on those calls and that is the worst feeling in the world because you could have, you just couldn't get there, right? Another example from the same study. So this is showing, again, survival to discharge versus, again, how fast they were given the epi. And the ones that did survive and the ones that were discharged, again, that number subsequently gets less and less the longer it took to give that epinephrine. Okay, and there's more studies out there like this, but they all pretty much come back with the same conclusion, is that the longer it takes to get that first dose, their survivability rates, not to mention their resuscitation rates, are exponentially decreased. Another study, and this was done, excuse me, as a presentation at NAEMSP back in, I think it was 2015. But this was Dr. A lot of you know the Hantevi method and all that. So Dr. Hantevi was part of this study along with a few others. And they did this whole cohort, and this is what they came up with. That in over 35% of the cases that they studied over this particular time period, that, well, I should say only in 35% of those cases that they had, epinephrine was even given, not to mention delayed. So in only a third of the cases did the kids get what they needed, right? Which again, their survivability was not very good. Another one here, again, another study that just came out recently. This is back from, what year was this? 18, so a little bit more recent. Same thing, and they come to find out here that kids that were administered epinephrine more than 10 minutes after EMS arrival was the norm. And a lot of it came down to just, again, response times. Every minute that delayed epinephrine was associated with decreased survival and obviously bad neurological outcomes, even if they did survive in those cases. And then this other study out of Japan, which kind of backed that up. Again, lots of data out there that says that the longer it takes to give it, the worse the outcomes are. Sir? That honestly is a good question. The question was that, would the administration of a pediatric EpiPen be better than nothing in a rural setting if you have just a BLS unit? It depends, because obviously as you're giving that, it has to be absorbed through the musculature. And we know how good the perfusion is normally in a cardiac arrest, even with good CPR. So it may be something that, I'm sure there's studies out there. I'm not aware of too many. I'd have to look myself and get back with you. But I would imagine that it would probably provide maybe some benefit if you were there soon enough. But the overall benefit, just because of the absorption, may or may not, it's going to depend on the patient, I think. And obviously their age and development too. So, but it's a good thought. Okay, next. So we talk about how epi's not given enough or at all, okay, or not fast enough. But so what, right? Because what it really comes down to is that in most of these cardiac arrests, and I'm not saying that delaying epinephrine is not a bad thing, because it is, but everybody in this room can do this, right? How many times have you been, in a pediatric class, and in some of the classes I teach, I never get past, I don't even go to a supraglottic airway. Okay, we talk about nasal airways, oral airways, good BVM, good mask seals, and quite honestly, that's going to cover a lot of your things in your kids. Good CPR, good, exchange as far as every 2 minutes, making sure the depth's correct, all that stuff. Because this is what's going to save them, at least initially. Now, is epinephrine going to help? Absolutely. Is an advanced airway eventually going to help? Maybe. But if we don't cover the basics, and this goes for adults obviously as well, but especially with kids, there's, like I said, their stuff's brand new for the most part. It doesn't have any underlying gunk and 50 years of McDonald's and all that other stuff in it. So they react better to what they need, which is what? Circulation and oxygenation. That's BLS, right? So I don't know what your services are like and what you have in your protocols, and obviously your protocols would dictate what you would do. But how many of you have already been using or are using like a pit crew mentality as far as your resuscitation? Good. Because all it's there to do is that, well, is it, is there something better than this? Do we have to do it? We don't have to, but it makes the resuscitation more efficient, because everybody knows what they got to do the second they show up. And especially when we're dealing with kids, that's a better thing, because we're all going to walk in there like chickens with our head cut off. It's like, oh my God, it's a kid. So if you got that focus, it's like, look, I know you're freaked out. You still got the airway. Get on it. Do your thing, right? You've got to do compressions first. Get down there. Let's go. So on and so forth. So this is just one example of obviously how that could be set up. And so you've always usually got 1 to 2 compressors. You've got someone up on the airway, someone on the monitor, the AED. Obviously, if you got the service for your ALS, you'd have someone on meds and the IVs. And then lastly, someone that's kind of just standing back as an unobtrusive third party and just watching the whole thing happen. And that's probably the most important person that's there. You got that person that's actually controlling the chaos. Because when we get in there and start doing our thing, we get tunnel vision. Whether we like it or not, it happens. Especially with kids, that tunnel gets even more narrow. If you've got that third person standing back there going, hey, by the way, you're not pressing deep enough. Hey, by the way, you want to ventilate this kid? Hey, by the way, can you press the button on the AED? That kind of stuff, which sounds silly, but it happens. And it happens all the time. And it's no fault of ours, because we're human beings. We get focused on certain things sometimes and we get dissuaded. So that person, again, keeps everything going the way that it should and keeping track of the time. All right, 2 minutes is up. Flip, let's go. That kind of thing. So the key is, obviously, especially with children, have a plan. Right? Don't be doing pit crew CPR for the very first time and then the arrest. Take some time out in your trainings and take some time even while you're on shift. Get back in that book. Do you have a resource? Do you use the hand tev, or you use something else that's out there? Have that stuff already out, ready to go. Get your Broslow tapes out. Get whatever it is that you're using as your resources. Have them out. Look at them constantly, and make sure, obviously, as much as possible, that you have the right size equipment. Sometimes we do and sometimes we don't, but we try to keep it there as much age appropriate as we can. Second thing is, make sure your compressions are fast enough, just like the adults. Right? And obviously we're going to do this, whatever it is, the 2 thumb, 2 finger, 1 hand, 1, 2 hand, whatever it is, the size of the child. Making sure, again, not so much, and this is important, but what's more important than the compression? Are they adequate? So are they deep enough? But then making sure you're letting that chest come all the way back up, right? Why do we let that chest come all the way back up? Exactly, because that's when that heart refills. If you're sitting there jackhammering on that chest, oh yeah, I got a heart rate of 180. It's all good. Right? But the thing is, you're pushing that much volume. Okay, you've got to let that heart refill so that every subsequent compression, you're getting a decent output, because you're hopefully delivering oxygenated volume to the brain. Remember, even at our best, this is anybody in this room, this is not being subjugated to anything else, because it's just a true fact. We can only simulate about 1/3 of the normal cardiac output with our best CPR, right? With all this right here. The mechanics just dictate that. So you want to make it as much as we've got here, we want to make it as efficient as we can. Obviously, like I say, let the chest come up, and then making sure that we're ventilating at the appropriate rate, that we're not overventilating. If you overventilate, what do you run the risk of? So I ventilate it, 30 times a minute. Either A, it goes in the belly, which does two things, right? Either it expands and presses up on the diaphragm so the lungs get smaller, or more likely B, okay, all the birthday cake and the pizza and the chili and the hot dogs and the Oreos and the Fruit Loops and all that stuff they ate comes north. A, it's disgusting. B, now they're aspirated. Now you got a bigger problem. Now you can't oxygenate them. All right. So we got to do that. And you also run the risk the higher you ventilate, you keep those lungs inflated and you keep that intrathoracic pressure too high. What's that going to do to the heart? Reduces output, reduces preload. So you're fighting against yourself. Okay? The rate is not very fast. It's enough to deliver enough volume with enough oxygen, basically 6 to 10 times a minute, give or take, depending on your child, and off you go. Okay, next thing. And everybody freaks out about this. You're like, are you freaking kidding me? Because you see a kid, what do you automatically want to do? And we did this all the time. Scoop and run, right? Well, again, lots of different studies that are out there. This was just one of them. I got a couple actually here, but they're both basically saying the same thing. This one came out of Canada back in 15. And they used, again, a roughly a skill set of about 2,200 patients. And what they were looking at here is that, okay, let's spend some time on scene. Does it really make a difference in outcomes statistically? And out of all these children that they used, as far as their examples, they eventually found that there was a sweet spot, okay, which still holds true now. Usually, they said it's somewhere between at least 10 minutes, but no more than about 30 to 35 minutes on scene is where you want to be. They said usually after about 30 to 35 minutes, the outcomes didn't improve, didn't make any difference. But what it did also point out is that the ones that stayed on scene, this stuff got done, which means we were doing CPR like we were supposed to. We were ventilating these kids like we were supposed to. They were getting the meds and their antidotes. They were getting the IVs started because A, we had more room. We weren't rushing. Somebody was kind of controlling the chaos and stuff got done, right? Because if you scoop and run, yeah, okay, remember, how long did it take you to get there to even contact that patient in the first place? You add another minute, 2, 3 to scoop them, run them out to the truck, finally get oriented. Now you're in the back with 5 people. You're trying to get your spots and more time's ticking away. Versus stay on scene, do in the living room. I mean, it's terrible because the family's probably going to watch, but you've got room to operate. You've got room to put your equipment down. You've got room to do your pit crew CPR. And they showed this numerous times throughout the study that this was much more efficiently done when they stayed at least on scene for more than 10 minutes. Okay? Same kind of study here done back in 19. And these were the things that, again, that they looked at as far as adding into this particular protocol. The use of supraglottic airways, controlling their ventilation rates, obviously getting IV or in this case rapid IO insertions, and early epinephrine as we talked about earlier. Adding all those ingredients into this situation, again, pit crew CPR, which they weren't doing at the time, here's what happened. Okay, this was done over a period of about 5 years. And so the first cohort they had 2 people that were resuscitated out of the 38 cardiac arrests with these kids, and none of them survived. None of them walked out of the hospital. The next cohort, they had 56 cardiac arrests. 17 were actually resuscitated. And out of those 17, by changing these parameters here, okay, again, airways, IOs, getting stuff done, the basics, 13 of those 17 actually walked out of the hospital. Then to the next cohort, they had 49. Okay? 23 of those 49 were resuscitated, and out of those 23, 17 walked out. So every time, statistically, it got closer and closer. It was like, oh, this stuff's actually working. Right? And they had the data to prove it, and it's right there. So it comes back to showing that there's survivability, and this is the end game, right? We can resuscitate anybody. I can resuscitate a rock if I really work at it. But to get them to be neurologically intact, ideally, but walking out of that hospital, yes, all right, this is what needs to be done. So in this case here, with those simple things, staying on scene a little bit longer, doing those airways, getting those IVs, doing good BLS, good oxygenation, good ventilation, early access to the epi if they can get it, it all makes sense. It all makes a difference. Now, that's the ideal situation, right? We live in that unideal world because every scenario can play out a whole lot differently. It can be 5 cardiac arrests. We're going to get 5 different ways that it gets done, maybe 5 different outcomes. But the more consistent that you are as far as staying on scene, getting those BLS procedures done, getting good airway and good ventilation to these kids is going to go a long way to having your chances improve. All right, now, what do we do this? Because like I said, if we're staying on scene, mom, dad, brother, sister, grandparents, cousins, next door neighbor, third person from the sun, whatever's going to show up, and they're all going to be there. This is where also that third person that's kind of standing back and kind of directing traffic can also be kind of crowd controlling at the same time. And the thing is that it's not a bad thing to let the parents, if they want to, if they want to stay there and watch, as long as they're not a hindrance, let them. Because God forbid, if this goes south and we don't get a resuscitation out of this, what's the benefit of those parents being there while you're doing your thing? Yeah. It's not going to change the fact that their child died, but psychologically, it'll be the beginnings of at least them being able to accept that everything was done, at least in their minds, what they perceived. Now, whether that helps or not, again, there's different stories about that, but it can. As long as, again, they're not being a hindrance. Make sure that that person is telling them exactly what you're doing. You know, why are you pushing on their chest? What's that thing they're putting on their face? What did you stick in his arm? What are you pushing through there? Why did his chest jump when you press that button? Right? They're going to have questions. And they're going to be asking the crew members to go, have your, basically your PIO, if you will, you know, be there to be telling them in simple layman's terms. They'll say, well, he was cardioverted with a joule wattage of 400 watt seconds. It's like, no. They put this on here to basically help create a way so that that turbulent rhythm in the heart that was causing him to be in cardiac arrest will be going away, or so, however you want to word it. Make it simple, right? If you transport the child, either way, one, don't let the family drive themselves for two reasons. One, because they're going to drive like banshees, right? And they're not going to be in their right mind, and they're more likely to get into an accident. Do not let them follow you, because you never know. I mean, you're going through, and if you've got the thing the right of way, you go through the intersection, the light changes, all of a sudden they get T-boned, right? I'll give you another real quick example. So we had a child that we were taking. He was a sick child. He wasn't cardiac arrest. He was really septic, and he was bad off. Picked him up at this hospital that we're taking him. Basically, we're at the middle of the state in Ohio. So we're going to Cleveland, which is about an hour away. And they're following us because they didn't know where they were going. And it is, the hospital we were going to was a little bit hard to get to. So we said, fine, but you need to follow at least 3 car lengths behind us. And I told them, if we turn the lights on, just do not. Okay? Just, it probably means that we're just trying to get there a little bit sooner, but there's nothing wrong, you know, that's going on with your child. Well, they're bumper to bumper with us the whole entire way out of that driveway for like the first 5 miles. And I'm looking back there. I told my nurse, I said, we got to do something. So we pull over on the highway. We pulled over. Nurse went back, talked to the dad, told him, and you can see him nodding his head and all that stuff. About 2 minutes later, you know, he's back on our bumper again. So we decided, okay, we're going to end this right now. So we call State Patrol. Say, look, here's a situation. Here's where we are. We need an officer out here to pull these people over and slow them down because they're going to get themselves killed. About 5 minutes later, 10 minutes later, State Patrol pulls up, car gets pulled over to the side, fine, we're gone. We don't see him for the rest of the trip. And so trip lasts another 45 minutes, give or take. Guess what happened? They beat us to the hospital. Yes, he beat us to the hospital. So that's how, you know, urgent that this situation can be, is that, and if you've got kids of your own, you can probably appreciate this as well, is that yes, you just aren't in your right mind. And I get it. We all get it, but it's not safe, right? So you don't want that to happen. The last thing, again, that we want is either them getting hit or them hitting us, and us, all of us getting into an accident, and obviously compounding the problem. Okay, last thing. So those are all the positives, right, that we can look to try to help and keep these kids on the up and up, or if they're in cardiac arrest, here's what we can do about it. But there are times where it's just time to pull the plug and just say we're done, right? Now, here's the thing. How many of you in here, honestly, and again, if you raise your hand or not, it stays in here, as far as you know. Okay. But how many of you are honestly willing to quit on a kid? Okay, there are a few of us. And sometimes it's just like, you know what? We're just doing more damage than good. And we are. But in comparison to your average adult, we're going to work these kids 4 times longer just because. Good, bad, or indifferent, it's just the way it happens. But there is a point where you just got to look at, or certain instances where you got to kind of assess, there's no way we're going to resuscitate this child. Right? And usually that deals going back to some type of traumatic arrest. right? So when we have that, and we have that traumatic out-of-hospital cardiac arrest, is it already occurred before we get there, or is it happening in front of us? There are a couple of things we start to think about, right? First off, right, should we proceed at all? And one of the instances is that it was a witnessed arrest, okay, and actually resuscitation was started before we even got there. So maybe the bystander was just doing their best job. Okay, it's better than nothing, right? Second thing is that, well, maybe there was a doubt of some sort as to when this actually occurred. Did it happen 4 minutes before we showed up or 40 minutes before we showed up? Nobody can give me a clear picture. So I make the assumption it happened just before we got here. Let's go, unless they tell me otherwise. Or there was some type of cardiac arrest that was caused by one of these 3 things. Okay, it was either a drowning, we talked about with that long QT, hypothermic patient of some sort, however that happens, or a lightning strike. Those 3 are kind of the asterisks, okay, the exceptions to the rule, so to speak. So if there's history of one of those 3 things, even though they're in cardiac arrest and they may not be survivable because of its traumatic in nature, because of those particular mechanisms, there is a high possibility that they can be resuscitated, right? So we still proceed with that. Now, other than that, we think about it, because if you've got what we call primary signs of futility, I mean, this is the Mr. Obvious one here, right? Child is missing body parts that they shouldn't be missing, traumatic amputations, in the chest or the abdomen. I mean, basically it looks like yeah, stop. Okay, don't even start. Maybe in some cases there's just no way to start because there's just not enough of the child left to start. I mean, it just gets kind of gruesome, but these are the ones that are obvious. However, we start looking at secondary signs. These are the ones that we see a lot, especially in adults, but can happen with kids. You see dependent lividity, which is what? Yeah, so you got the pooling on the posterior, usually because they're laying supine. They're already in rigor of some sort, or there's already obviously signs of decomposition. Again, common sense is going to tell you, doesn't matter how much you want to try to resuscitate this child, it ain't going to happen. They're well past that point with this. Now, we go back to those drownings, the lightning strikes, and the hypothermic kid. Those are the traumatic ones we may try on no matter what, unless you've got a drowning, lightning strike, or something like that that has one of these 2 instances associated with it, which goes without saying, okay? So, again, we're going to come across those every once in a while, and so we go ahead and try to do it anyways. Again, if you get to the point where you're at 30 minutes or longer, like I said, that sweet spot normally, even if your stay on scene was like 30 to 35 minutes, whether it's medical or trauma related, even if they do get resuscitated, their neurological outcome is universally garbage, right? They never come back like they're supposed to. The other thing is that a lot of these kids have probably had some kind of really bad head injury. Why? With younger kids, what's the majority of their body mass? Their head. So when they fall, okay, or they get ejected or whatever, where do they lead with? Their head, which means by gravity, what hits first? Their head, right? And you kind of just put the puzzle pieces together there. So you've got that on top of the fact that, that it contributes to those poor neurological outcomes that we see with these kids. So, anywho, how many of you have debriefs after every cardiac arrest, or especially with kids? If you don't, you should, right? Because as tough as we think we are, right, it's still going to get in your crawl at some point. So it's okay to talk about it, and you should. Give yourself some time. Heck, our protocol stated that if you came across a cardiac arrest in a child, you're done for the rest of the shift and the shift after that. But you were also mandated to talk to the chaplain as well, because he was a counselor on top of that. And just nothing in particular about the call itself. They just let them get it out, because some people obviously don't do as well with this as others. So take that time, encourage your teammates to do the same thing, because kids dying is not natural. You're not supposed to. Sometimes it does, and it's terrible. But especially if it's something where we're involved and the resuscitation doesn't go well, that makes it even worse for us, because it's like, what else could he have done? The whole what if thing, right? You can what if this thing to death, and that just eats you away too, to the point where your mental health is severely compromised as a result. So don't be afraid to talk about it. And like I said, you guys are going to get my information up here. I know I'm in Ohio, and you're all out here on the West Coast, but you get a call like this and you need someone unobtrusively to talk to, I said, call me. I'll listen. I tell this to everybody. I don't care where you're at. I may not be able to have the answer for you, but at least I'll be that ear that somebody else maybe needs. So feel free. Anytime. All right. So with that depressing, a little something to leave you positive with here. It's like, I do know the force. Yes. All right. So I know we got one more lecture here, but as I promised earlier, if you guys want to take a picture of this QR code, hopefully we'll come up here. This is actually my nephew who played at Troy when he was younger. Let's see if I can advance it one more slide. Should go one more. Yeah. So you take a picture of this. This is going to send you right to my website. If you look on the menu, if you go through the menu on the website, you'll see a contact page, and it's got all my information, my phone number, my email, all that stuff. I'll send you this or anything else. And like I said, you get in a pickle and need some help, give me a call. I'm glad to help you. Otherwise, hopefully I'll see some of you tomorrow. And thanks for coming. Appreciate it.